This is Emily Peters recording for Advanced Concepts of OB-Peds, the lecture on HIV, sickle cell, and leukemia. Okay, so this should be a nice review for you. Some of the functions of the hematological system. So when looking at the possibility of a child that could have hematological issues, you need to ask the patient or the patient's family about fatigue or signs of malaise, the pallor of the skin, were they having any unusual bruising, excessive bleeding, or difficulty with getting bleeding to stop. So anemia. We've talked about anemia in the past, but we have different types. Nutritional deficiency, toxin exposure such as lead poisoning, aplastic anemia, and hemolytic anemia. Sickle cell disease we're going to concentrate on, and that is a form of the hemolytic anemia. So hemoglobinopathy. Sickle cell, hemoglobin, sickle cell disease, A thalassemia, and B thalassemia are all forms of hemoglobinopathy. This is a condition where there is abnormal hemoglobin that is present. So with sickle cell disease, as you can see, there are some abnormal hemoglobin cells or red blood cells there. Okay. So with sickle cell anemia, the patients don't have problems until that adult hemoglobin starts developing and is being replaced by hemoglobin S, or the sickle cell hemoglobin. Okay, so babies are born with that fetal hemoglobin, and that rapidly decreases during that first year of life. So at birth, if we were to do a blood smear and look at their hemoglobin or their red blood cells and their hemoglobin, at birth you're going to see normal hemoglobin because we're seeing that fetal hemoglobin and it hasn't been replaced by the sickling hemoglobin. So we can't diagnose them with sickle cell disease until they with blood smear. Okay, so we have other testing which I'll talk about in a little bit. When that adult hemoglobin is being replaced by sickle hemoglobin, we end up with abnormal adhesions and entanglement and enmeshing of rigid sickle cell shapes. And then it causes blocking of that microcirculation. And if I have a block in my microcirculation, that can lead to vaso-occlusion. Okay? And if I'm having vaso-occlusion or a blocking of some of that flow, then I'm going to have possibilities of hypoxia, maybe even ischemia, and possibility of infarction or cellular death. Most of the complications to the due to this vaso-occlusion ends up like stasis of enlargement of the organs. And we can also have infarction and ischemia and repeated destruction of like the cells and the tissues and organs. Okay, so once again, pathophysiology. Partial or complete replacement of normal hemoglobin with these hemoglobin S cells. Okay, they're not going to start having problems with this until those kids are getting closer to the year age, because it takes a while for all that fetal hemoglobin to be completely depleted. Okay, and what's going on is, and if you look at that picture on the last slide, the hemoglobin takes on that elongated sickle shape, so they can be kind of C-shaped, S-shaped, something, okay? And that shape causes that blood cell to have a shortened lifespan. Okay? All right, so this is a slightly different picture than what's in your book. And you can see in that picture A what a normal cells look like, and as they're going through our veins we don't have a problem. But in picture B you can see we have some of those sickled cells, and we're starting to have a problem because they're kind of enmeshing and tangling together. And repeated issues, or when we have that destruction, that infarction, etc., these patients could end up with tons of issues. Infarctions with pneumonia, pulmonary hypertension, atelectasis, CHF, anemia, strokes, blindness, hepatomegaly, because if I'm not able to get the blood cells out, I'm going to end up with an enlarged liver. Splenomegaly, so my spleen's going to enlarge. Issues with my urine, pain, okay, priapism, so osteomyelitis, ulcers, things like that. There is no cure at this time for sickle cell disease. Can we do blood marrow transplants? Yes. Could that possibly cure it? It's possible. Because what are we doing? When we do bone marrow transplants, we kill everybody we basically kill off the patient's bone marrow, and then we replace it with new. So could that possibly be a cure? Yes. So what do we do for these patients? Supportive care, prevent sickling episodes, help them with their pain, help them when they're having crises. Okay, with sickle cell disease, we're not going to bleed out, because what's our problem? We may have like an injury and clotting, and we'll clot and we'll have blood pooling, but we're not going to bleed out. Okay, because if I have a cut, my cells are going to all enmesh, and we're going to end having enmeshing of those cells at that site. So it's not going to be a bleeding out issue. But we could have pooling of blood in my spleen if I were to have an injury, or things like that, because we have no place to go due to the clotting, I guess, of all those cells enmeshing. We can have bacterial infections that occur because they're going to be immunocompromised. Infection tends to be the leading cause of death for these kids. And then, of course, strokes. So if we can prevent strokes and getting treatment for these kiddos sooner rather than later, maybe we can decrease some of that long-term effects. In your book, we have a chart that breaks down acute versus chronic manifestations. So I'd have you look at that. Okay. Some things that increases somebody's risk for going into like a sickle cell crisis would be like trauma. So I have an injury, and what happens? So I have an injury, and what happens when you have an injury? You get a bruise, or you get something like that. And so what does that cause my body to do? Produce more red blood cells and produce more antibodies and things like that. So what's going on is I'm producing more of these sickling cells. And what's that going to cause? A crisis, because it could cause a decrease in that microcirculation. It can cause infarctions. It can cause clotting and enmeshing of those cells. Infection, fever, stress, physical and emotional. When I'm dehydrated, what does that do? That makes my blood more viscous, right? More thick. And so I want to decrease dehydration if that kid's sick. Hypoxia. So kids that are, if I need more oxygen, what's my body going to do? Produce more hemoglobin cells to carry the oxygen. So that increases the risk of us producing more of these sickled cells. So if I'm going up in high altitudes, even poorly pressurized airplanes, climbing Mount Everest, whatever the situation may be, that increases my body's need to produce more cells to carry oxygen, and that could put that patient in a crisis. Hypoventilation, vasoconstriction due to being hypothermic, things like that. There are several different types of sickle cell. We have vaso-occlusive. This is the most common type. It's very painful. You end up with stasis of the blood, which means that you're having clumping of those cells in that microcirculation, which then leads to what? Ischemia and infarction. So signs and symptoms would be fever, pain, tissue engorgement. Then we have the splenic sequestrian. Okay, so this is going to affect the patient's spleen, which means they could have some life-threatening issues and death can occur within hours. Think about what your spleen does. Okay, so I have an injury to my spleen, or the vaso-occlusion is occurring and it doesn't allow blood to get out of my spleen. And therefore I get blood pooling in that site. That leads to anemia, hypovolemia, and shock. Then there's a aplastic crisis. I have a decreased production of red blood cells, but my body is also having an increased destruction of red blood cells. So I'm producing less red blood cells and my body's killing off more red blood cells. And this can be triggered by a viral infection or a low folic acid. These kids are going to have profound anemia and pallor. Then you have the hyperhemolytic crisis. We just have a very fast rate of destruction of those red blood cells. So they're still going to be producing them at a normal rate. It just means I'm decreasing, I'm killing them off faster. Okay? Anemia, jaundice, and reticulocytosis is a problem. So these are some diagnostic studies. Okay, so we're going to look at the patient's hemoglobin. Their baseline is usually around 7 to 10. With splenic sequestrian, it's going to be lower. Okay, same with that aplastic crisis. We're going to look at the reticulocyte counts. So reticulocyte counts means that I am reticking. Okay, so I'm reticking, I'm producing red blood cells. They're going to be greatly elevated. Okay, the peripheral blood smear. This is only a diagnostic study when that patient is an older child. It is not going to be effective in an infant. An infant will still have fetal hemoglobin, and I will not be able to see sickle-shaped cells until they're getting closer to a year or older. Platelet count will be increased. The ESR is a good indicator. It's going to be elevated. And then we're also going to look at abnormal liver function tests and their bilirubin levels. Okay, so once again, peripheral blood smears are only going to be a diagnostic tool in children that are older. Infants or a newborn, they will not have or young infants and newborns will not have sickle-shaped cells because they have fetal hemoglobin that is working for them, and they have not started to produce adult hemoglobin. Okay, diagnosis of sickle cell in those infants. What we are going to do is a hemoglobin electrophoresis. Okay, this is going to be doing through the cord blood. We're going to be doing genetic testing to identify those carriers in children. Okay, by looking at the cord blood, and we can identify that child has sickle cell before they have symptoms, because once again they're not going to start having symptoms until they start producing adult hemoglobin, which is going to be when they're getting closer to a year of age. Okay, hemoglobin electrophoresis distinguishes between a child that is a carrier and a child that has the disease. So it's looking at those fingerprinting proteins that determines if it's a carrier or they have the disease. Okay, the sickle turbidity test is a quick screening for those kids that are older than 6 months of age. Okay, it may not, the sickle dex does not look at the fingerprinting proteins, but that it could be a good tool as well. If this child does not get the hemoglobin electrophoresis, at birth or soon after birth, a lot of the times they're not diagnosed until they have a crisis. And typically we know with respiratory or with pediatrics, especially the younger they are, they tend to have respiratory infections. And that's when we're going to see them with a problem. Or even a possibility of like a GI infection. Okay, management. From the ages of 2 months to 5 years, these kids will a lot of the times get oral penicillin to help reduce the risk of pneumococcal sepsis, because remember, they're immunocompromised. We're also going to look at their reticulocyte count regularly, because that's going to evaluate how their bone marrow is functioning and are they producing cells. We can do blood transfusions early in a crisis because that's going to reduce the ischemia, and that's also going to get some healthy red blood cells going, and it's also going to get more fluid in there, right? So therefore we are not going to have a thick, viscous blood. We can also I forgot what I was thinking. If there's low iron in the tissues or high iron in the tissues, we'll want to do chelation therapy for these kids as well, because that's going to cause some problems. Okay, and we want to excrete extra iron. Once again, preventing sickling phenomena is important. Remember, bacterial infections can be one of the leading causes in these children, and they can have strokes. And when we have a stroke, what's this going to do? Cause neurodevelopmentally delays and could lead to mental retardation. Okay. So these patients, we are going to recommend electrolyte replacement. Okay, so if I'm hypoxic, that's going to result in metabolic acidosis, which then leads to sickling. So if I'm replacing the electrolytes, that's going to help offset that metabolic acidosis. We also want to give them fluids, because if they are dehydrated, that's going to increase the risk of that sickling to occur and the clotting and the enmeshing of the cells. We can give analgesics for that severe pain from the vaso-occlusion that is going on. Okay, what we give them will depend on the pain level. So it's fairly low, we might just give them some Tylenol. But if that pain is severe, they may need pretty strong pain meds. Blood replacement to help treat any anemia and also to decrease that viscosity. Antibiotics to treat those infections, because if we don't treat those infections, we're not going to help that child. These kids can have growth issues, so we're also going to watch them for failure to thrive. These kids, we are not going to want them to do high energy, high expenditure types of sports, because what does that do to our body? It requires more oxygen. Okay? We're going to assess pain. We're going to observe the presence of inflammation. Monitor for signs of shock. Okay? Immunizations are important for these kids. Financial needs. We're going to talk about all that financial information with them. Caregiver role strain. Living with chronic illnesses. Also, don't forget about the ABCs of a sickling crisis. I believe that was one of the questions that was in your focus questions, and how that works and the importance of how we do our steps. Okay, education is very important for the parents as well. So here's some other treatments that we might do. Cholecystectomies, splenectomies, hydroxyurea, because that may increase fetal hemoglobin. This is a trial. I don't know much about it. Blood transfusions, like I've discussed. Partial exchanges. I think I've talked about this before. A partial exchange means I'm going to be taking so much of the patient's blood out and replacing it with like a normal saline. And what's that going to do? It's going to change the viscosity and dilute out the system. And then we can do the stem cell transplants. So, when we're worried about a patient with a hematological issues, there's some different things we want to look at in their birth and maternal history. Were they low birth weight? Was there gestational diabetes in the mom? How soon was vitamin K given after birth, or was it even given? Because that can give us an indicator with clotting. Because if we don't give vitamin K soon after birth, the clotting factor may be affected. Were they ill? How that child sleeps. Are they stooling okay? Is there blood in the stools? Their family history. What's their diet like? So if they eat a low iron diet, maybe that's part of the problem, reason why they're having anemia. Okay. And then if we're looking at a crisis due to too much iron in their system, or too much lead in their system, then maybe we need to look at that lead exposure as well. So here are some common diagnostic tests that we will do for patients that we think have a hemoglobinopathy issue. So blood type and cross match, because that's going to tell us their blood type and figure out what we need to do. How are they clotting? Their coag factor, the CBC and diff. That's going to tell infections, but also going to give us an indicator of how many of each types of cells they have. Hemoglobin electrophoresis is going to tell us a lot about their cells. The iron and lead levels, reticulocyte count, and the ferritin level. This is a chart of normal hemoglobin gram values that would be helpful maybe for simulation for you guys. As you can see, it's not too extremely different than the adult levels, but when they're a little bit younger, the numbers tend to be a little bit higher. Here's some example of some nursing diagnoses. I'm sure there's many others that we all could come up with. And some treatments. If we have never heard of these, look them up. Blood product transfusion, oxygenation, stem cell transplants, and splenectomy. Alright, so here's some of that teaching that we need to give the parents. What to do if my child is having a sickle cell or vaso-occlusive event. Priapism. My little boy is having a painful erection that won't go down. I need to go see a doctor because that could be a sign of problems. Swollen joints, pale and listless, fatigue, headaches, coughs, signs of being sick, fluid buildup. Granted, they're not going to bleed out, but if I don't have any place for that blood to go, if I've had an injury, I'm going to have fluid building up because it's not going to have a place to go. Okay. Febrile illness. Have they had their vaccinations, and the importance of getting them, and the importance of doing that penicillin prophylaxis. Making sure they're getting a good fluid-filled diet and healthy fluids. Okay. And what kind of activities are appropriate for this patient. All right. HIV/AIDS. Okay. So I'm hoping you've heard of HIV and AIDS before. We have a couple different types of transmission, and hopefully this is just reviewed to you. Horizontal, which is sexual contact, blood, and body fluids. And we also have vertical transmission. So this is perinatal, HIV-infected mother to the child. Okay. With HIV/AIDS, your CD4 cells and your T cells become dysfunctional, and that allows these opportunistic cells of the HIV to overtake the system. Okay. We can diagnose infants as early as 1 to 4 months of age. So it is possible to diagnose them early and get that treatment early. Okay. So some things to look at when you have a child that has an immunological disorder, not just HIV, but some things that we need to be aware of. Does that mom have HIV? Are they having frequent or recurrent infections? Because that could be a sign of even like cancers or HIV. Chronic cough, recurrent low-grade fevers, 2 or more serious infections in early childhood, recurrent deep skin or organ abscesses, because those are not normal in pediatrics. thrush in the mouth is also not a normal thing in pediatrics. Granted, some infants do get it due to poor cleaning of like nipples and bottles, or sharing of nipples, bottles, pacifiers, things like that. Extensive eczema and kids with growth failure. We need to figure out what causes it, and that could be an immunological disorder. So some diagnostic testing for HIV infection is the PCR test. This will be positive in infected infants that are older than 1 month of age. The ELSA, I never pronounce this right, enzyme-linked immunosorbent assay is going to be positive in infants of HIV-infected mothers because of transplacentally received antibodies, okay? They may be detectable for up to 24 months of age. So it's not as accurate in our infants and toddlers. The PCR would be more accurate, okay? As we know, the enzyme-linked immunosorbent assay is also used for detecting other issues as well. Platelet counts. If I have platelet counts above 500,000, that's a pretty good indicator as well. And then my CD4 counts are going to be really low. Okay. Antiretroviral drugs are very important in the management of children with HIV. Okay. As we know, those antiretroviral drugs is going to help prolong the lifehood of that child. Okay. And adherence is a huge concern of the nurses. Our book talks about the HEART program, the highly active antiretroviral therapy for HIV/AIDS. Okay. We also need to make sure that these kids are getting their immunizations. We also need to watch these kids for signs of failure to thrive and their nutritional deficiencies. They're not going to always want to eat. They're not going to always want to drink. So we've got to follow them closely to make sure they're developing normally. These kids are also going to be at high risk for pneumocystic carni pneumonia because they're immunocompromised. Okay. So we are going to also do prophylactic treatment of flagells or some of our sulfas. Okay, and here's one of them. Education. So what kind of things should we educate on? The transmission. Okay, it's incurable and highly expensive treatment. The importance of taking their medications as prescribed. If the child does not have the disease yet, it's important that we need to teach the mother good ways to prevent her transmitting the infection to her new child. We also need to teach them to allow that child to have as much normal development as possible. We don't want to ostracize that child. Okay? Safety issues. Once again, the transmission. Things that that kiddo could be at high risk for. Pain management is more towards when they're getting their treatments. If they're getting a shot. If they're getting IV antibiotics. Things like that. HIV is not necessarily a painful thing. Okay, what kind of assessments are we going to look for? Failure to thrive, poor nutrition, puking, blood in the urine, signs of infection, psychological concerns, things that could be mentally going on with that child as well. Okay. Mothers, most of the time, if we have a child with the disease, their mother has the disease because that's probably where they got them. So we need to encourage that mother to do her self-care and to take her meds as well. Some other things, disclosure of the diagnosis. Our book talks about by the age of 6 because that's when the child is going to start asking more questions and realizing something is going on. So then, how do we tell them? What do we tell them? It's going to be individualized per child, of course, but we also have to think about, they need to be aware so that they can be taught different things to keep protecting themselves and others. Some other things is custody. Who's going to get this child if that parent passes away? Also, my child is dying and the parent is dying, but there's other kids that are completely healthy. So what do we do with that? And so the psychological concerns that way. How about financial difficulties? The cost of antiretroviral drugs are enormously high. So not only does the patient have it that we're taking care of, but probably one of their parents. And they need to take care of themselves as well. The stigmas with HIV and people not wanting to be around them because if I share a toilet, they're going to get it. The secrecy. Should I tell people? Who should we tell? Who, they don't have to tell people. Okay. And then these kids are going to school. What about the safety of others? So, yeah, should we educate the family? The school. Yeah, there's probably should be somebody at the school that's aware. They don't have to tell the school. Okay, because should all teachers and nurses at school be doing standard precautions? Yes. But is it good to let them know? Yeah. Okay, so there's lots of issues, that, the barriers that they have to come over, since they necessarily don't have to tell, okay? They don't have to disclose, but would it help with safety? If that child knows they have the disease, or even if they don't know the disease, but if the parents are constantly using standard precautions on that child to help prevent spread, then that child's going to learn that something's wrong if somebody is touching their blood or touching their scratch without gloves, or if somebody is doing something. So maybe that child will speak up. Oh, you better wear something. Things like that. Okay? So here are those signs and symptoms. Failure to thrive, bacterial infections, increase in those opportunistic infections, chronic or reoccurrent diarrhea, that persistent, unexplained, reoccurrent fever. These kids are going to become developmentally delayed, quite possibly, depending on how it's affecting their growth and development and their bleeding and their medications they're on, Candidus and, thrush. And that hurts as well. So if I'm not eating correctly, that's going to affect my nutrition, and therefore nutrition can cause developmental delays. Okay, signs and symptoms are going to vary per child and the severity of their illness. They're going to be shorter in stature, quite possibly, malnourished, cardiomyopathy. They could have CNS abnormalities due to infections, and then neuropsych deficits. Like I said a few minutes ago, developmental delays, motor skill deficits, communication issues, behavioral issues. They can have hepatosplenomegaly, lymphadenopathy, oral candidus, failure to thrive, pruritus. Okay. Okay, so nursing goals. We're going to avoid infection, right? So we're going to do everything possible to decrease infection. So these kids may not want to have a lot of live plants around, or at least in their hospital room. We may make sure if we're using fresh fruits and veggies that we're cleaning them really well. Continuing to educate and helping them with getting their medication and staying on top of it and being compliant. Helping them get good nutrition. So providing them with places to go to get that well-bounded diet. Pain management and comfort when they're having their treatments. Educating not only that child but their caregivers so we can help decrease the likelihood of passing on infections to the HIV, to any colds that they may have. And then just reoccurrent psychological and social support. Financial issues, this could be one. The diet. The fact that people treat them differently. They realize there's something wrong with them, but they don't understand it. The stigmas. stressors. It's an incurable disease. Financial difficulties. We've discussed a bunch of this. Okay. One big things that we can do as nurses is work with the hospital schedulers when we know they're going to have lots of appointments, and helping be advocates for the parents and the patient. So setting up appointments when the parents are having appointments, or setting up things around other appointments so they're not having to miss lots of school or miss lots of work. Helping them figure out financial help for all these appointments and hospitalizations. Yeah, granted, we as nurses don't know all of that stuff, but can we get them in in contact with like our social workers on the in our hospitals or our clinics? Can we get them involved with continuity of care nurses who work hand on hand with this social workers? People, other people that, know this, more of this stuff. I can look up some things on the internet as well, okay? Okay, we've discussed a lot of this, but think about what are some ways to decrease stress? What are some important things about the medication? Things like that. All right, childhood cancer versus adult cancers. Cancer accounts for the most deaths from disease in children older than 1 year of age. We do have an 80% survival rate for childhood cancers. We have a great comparison chart in your book that compares like pediatric cancers versus adult cancers. Definitely look that up. I just have a few snippets from you. Some other things, prevention in children is little is known, whereas in adults, 80% of cancers are preventable. With children, metastasis is typically present at the diagnosis. With adults, we're usually diagnosing them, and then metastasis occurs because treatment isn't going well, or because the family and patients have refused the treatment. Pediatric cancers, as my slide shows, develop from embryonal and neurodermal tissues. Okay, sarcomas, lymphomas, central nervous system tumors. Whereas adult cancers arise from epithelial cells, and they result in carcinomas. Okay. Okay, so some of the warning signs of cancer in children. Blood cell production. So these kids are going to have fatigue, pallor, frequent or severe infections, or easy bruising. Compression, infiltration, or obstruction caused by the tumor. So we're going to see bone or abdominal pain, pain in other parts of the body, swelling, unusual discharges. There could be many other things as well. Okay, so the most common childhood cancers in order of frequency. So leukemia is the most common, whereas retinoblastoma is the least common. CNS tumors, lymphomas, neuroblastoma, rhabdomyosarcoma, Wilms tumor, and bone tumors, osteosarcoma, things like that. We've talked about the bone tumors before. We'll talk about Wilms tumor later. We're going to focus on the leukemias because those are the most common. Some brain tumors I'm throwing out there as well that you might see in our pediatric population: medulloblastoma, brainstem gliomas, epidemiomyoma, and astrocytoma. Okay, so leukemia is the most common. My husband had an acute form, or ALL. Okay. It accounts for 1/3 of childhood cancers. Leukemia is a disorder of the bone marrow in which the normal elements are replaced with abnormal white blood cells. The biggest complication of leukemia is metastasis to the blood, the bone, the CNS system, the spleen, the liver, and other organs. And this can also cause alterations in their growth. Okay. You can also have ALL, or AML, acute myelogenous leukemia. Chronic leukemia progresses more slowly, permitting maturation and differentiation of the cells. Okay. And they may retain some of their normal dysfunction or normal functioning. So of the types of leukemia, ALL or acute lymphoid leukemia are the most common. It occurs between the ages of 2 and 10 years of age. Prognosis is very good. However, if there's a relapse, prognosis goes down from there. ALL is defined as an unrestricted proliferation of immature white blood cells in the blood-forming tissues of the body. You have infiltration and replacement of any of the tissues of the body with these non-functioning leukemic cells. The highly vascular organs are affected, such as spleen and liver. Okay. ALL, you may have heard of AML or ANLL, acute non-lymphoid or myelogenous leukemia. Okay. AML incident peaks during adolescent years. It affects the myeloid cell progenitors or precursors in the bone marrow. The complications of AML includes treatment resistance, infection, hemorrhage, and the metastasis. AML is less responsive to treatment. Okay. 3 big issues related to infiltration of the bone marrow. They can have anemia, they end up having infection, and increased bleeding tendencies. Okay. Their bones can be weakened, and so they're going to be at higher risk for fractures. They can have severe pain as that leukemic cell invades their periosteum. Okay. So anemia, they have that decrease in the red blood cells. Infection due to being neutropenic. Bleeding tendencies because they have a decreased platelet production. Okay. Another thing when we hear about leukemia and how it works, this is a good education on the pathophys that we can share with families, is that these proliferating white blood cells attack those normally functioning cells. That is not what happens. Your leukemic cells are not attacking the normal functioning cells. What's really happening is we're having a proliferation of those white blood cells. But the mature cellular elements are actually depressed. Okay? Those healthy cells are depressed, and because of the depression, that allows for those leukemic cells to compete for the nutrients in the bone marrow. And so therefore, the leukemic cells are stronger, and they compete for the same nutrition, and they take the nutrition, which then causes those mature white blood cells, those normal white blood cells, to die. So it's the cells aren't attacking the others, the healthy cells. They're actually just taking away the nutrition, and those healthy cells are weak, and they're taking away the nutrition, so therefore they die off faster, and allows these leukemic cells to proliferate and be stronger and to take over. So some things to look at in that patient's history: the pallor, the fatigue, fever, petechiae, pain, frequent bleeding, okay, like bloody noses, to other things like that. Fractures, liver and spleen enlargement. We're going to look at the peripheral blood smear, and we're going to see immature forms of leukocytes. They're also going to have low blood counts. We're going to do bone marrow aspirations or biopsies, and lumbar punctures. Okay, the unusual bleeding or bruising, unknown causes for those fevers. We're also going to do CBCs, liver function tests, BUNs, creatinine, and chest x-rays. The lumbar puncture tests are actually going to be done after diagnosis. So LPs aren't really going to diagnose for the leukemia, but it's going to look at what's going on with the CNS system and see how far it's involved. Okay. So treatment, chemotherapy, radiation. Okay. ALL has really good remission results. So with chemotherapy and radiation. So a lot of the times that chemo and radiation allows this patient to go into remission, and then they are them to go back to being healthy, and then they don't usually go into remission and need more. AML has poor prognosis, so bone marrow transplants may be used earlier. So if with stem cell transplants, ALL, usually we won't do them until they've had more than one readmission. AML, they will probably have stem cell transplants during that first readmission. Morbidity and mortality with transplants are high. Okay, so if you think graft versus host disease, overwhelming infection or severe organ damage. These kids, when they're having stem cell transplants, they have that chance of their body fighting off the donor cells and attacking it and getting sick. So they may have to take anti-transplant meds. They may have to be on other things longer. They can get super sick if they are not dealing with that transplanted organ very well. Okay. Some other things I want you to look at is for the separate books, Kyle book on page 1045 is a great table as well to look at regarding treatments. Okay, prognosis. Some things that are kind of interesting related to prognosis. What their patient's initial white blood cell count can give us a good idea of how their prognosis is going to be. So those kids that have normal or a very low count and what cell types are being involved have a better prognosis than those that have a extremely high count or an extremely low count. Your age at diagnosis. So those kids between the ages of 2 and 9 have a better prognosis than those kids that are younger than 2 or those older children that are 10 and older. Okay, girls have a better prognosis than boys. Another little interesting thing, I like genetics, so another interesting thing is if you're looking at the genetics is you can look at their DNA index, 1.16, and if they have a translocation of chromosomes 4 and 10, they actually have a better prognosis than people that don't have that translocation. I just find it very interesting that just looking at somebody's DNA, what you can find out. Okay. I'm not going to spend tons of time lecturing over this. What I want you to think about is what kind of care will I need to be doing? So I need to prepare that child and family for diagnostic and therapeutic procedures. So what do? That education and support, explaining procedures, relieving their pain, opioids, over-the-counter meds, non-pharmacological as well. So what are those non-pharmacological things we can do for them? We need to prevent complications related to myelosuppression. Okay, infection prevention. So how do we prevent infection? No live plants and no fresh fruits and veggies, right? The hand washing. Okay, looking for fevers, assessing for fevers. Looking at those sites where there could be infections. Making sure we have good nutrition, good protein calorie intake. Bleeding tendencies. So what do we do with somebody that has an increased risk for bleeding tendencies? Avoid punctures. Good mouth care with those super soft brushes. no shaving with straight razors, right? Good perianal care. No drugs that could cause fissures, right? No activities that can increase the risk for injury or bleeding. Platelet transfusions we may have to do. They're going to be at high risk for those nosebleeds and gum bleeding. Fixing anemia and doing things that are going to help minimize the oxygen demand. Okay, look at the nursing care plan in this book, in the book related to leukemia. What I have written down for the one book is pages 1032 to 1038. Okay, so this is some other things that are kind of interesting that the doctors look at. The absolute neutrophil count, and this is going to tell us a lot. Bands and SIGs are huge, besides looking at their white blood cell counts. Okay, preparing and administration of chemotherapy. Not everybody can do these, right? And not everybody can prepare them. So these are going to be specialized trained nurses. We're also going to make sure they're wearing good PPEs, double gloves or special gloves, gowns that won't be able to be permeable, masks, shields, different things, special equipment to get rid of the the liquids, the fluids, the medications, all that stuff, so that it doesn't spread to somebody. So just like we have special containers for blood products, we're going to have special containers for people that are using chemotherapy drugs. So typically it's like a white container with yellow packages or yellow lining or words or something like that. So some side effects, and I'm sure these are only a few of them. Immunosuppression, infection, myelosuppression, hair loss. And this is only after I've had chemotherapy, right? So remember, know what the side effects are of somebody that is just being diagnosed, and then the side effects that they're going to start having once they get radiation and chemotherapy. Long-term, dental issues, hearing issues, GI issues, cardiac issues. They can become sterilized. They can have effects of their growth and development. Radiation has some side effects as well, and some of them are similar to what we see with chemotherapy: fatigue, nausea, vomiting, issues with their skin integrity, myelosuppression, changes in their growth, hormones, hepatic, sexual issues. Like I said, sterilization, renal issues, long-term bone issues. They can be at high risk for secondary cancers. Okay, these are all things we'll have to talk to the families about, especially if we need to do planning for later in life. So promoting adequate nutrition is humongous in our children with cancers. We need to know what their body weight is. We need to know their length. Is it normal for their age? And if not, how do we help them? Okay. We need to know what the child's food preferences is. And then when they're hungry, we provide their favorite foods as allowed. So if their favorite foods are fresh fruits and veggies, unfortunately, we're not going to be able to do them. But can we get them those same things that are frozen or been cooked? We're going to need to do increased calorie shakes and puddings. Okay. Antiemetics to help with the nausea and the vomiting. We're going to weigh them frequently. And also make sure we're educating the parents on when to weigh the child. Same time, same clothes every day. My good rule of thumb is first thing in the morning, right after they go to the bathroom, and before they get their clothes on. Okay? Go to the bathroom, take all your clothes off, go to the bathroom, get on the scale, put your clothes back on. Simple, right? Highest calorie meals when their appetite is the greatest. So when they are always hungry at 5 in the morning and they always seem to have a good appetite, give them what they want to eat then. Get those high calorie shakes and puddings. Give them their favorite foods at those times. Give them vitamin and mineral supplementations. These kids may end up with central lines, Broviacs, to PIC lines, to all sorts of other things, and we may have to do long-term total parental nutrition like CVN, things like that, to help with that nutritional deficiencies that they could be going through. Education for the family. Make sure that they always have a copy of that patient's medical plan when they're traveling, so that if something were to happen while they are out of town or gone, then they can get accurate treatment at that local, whatever hospital they're near. Helping them keep track of all of those appointments that they're going to be going through. Labs, to frequent medication type things, to just regular checkups, to screenings, things like that. When to seek immediate medical care, what to do. Remember, they need to avoid crowds, keeping them protected during the winter, avoiding large crowds. What was one of the other things that is common? They may not be able to get their chickenpox vaccine, and chickenpox could be deadly to these kids, so that's something to be aware of, so that they're not being exposed to kids with chickenpox. Issues like that. Signs of a worsening condition or illness that they need to be aware of, and when to call the parents. And once again, don't give them aspirin. Oh, hyperbilirubinemia. So we've heard of this. You should be able to educate me on this one, because this should be some review. So, hyperbilirubinemia. I have an imbalance in the rate of bilirubin production and elimination. Okay. We should have bilirubin levels of 0 to lower than 5. Okay. If a kid has a level of 5 or higher, then we may have some problems. Okay. We have physiological jaundice, which occurs during that 3rd to 4th day of life. It could be early onset breastfeeding or late onset breastfeeding. We also have that pathologic jaundice that occurs within that first 24 hours of life, which could lead to like kernicterus. With kernicterus, the child's body is attacking things, and it goes to the brain, and you can have a lot of neurodevelopmental issues. And then that Rh isoimmunization and ABO incompatibility, which I have broken down in further slides. So some risk factors for hyperbilirubinemia: premature infection, Rh incompatibility, breastfed, I'm sick, poor nutrition, things like that. So jaundice, so the yellowing of the skins. What do? We need to reduce bilirubin levels. So feed that kiddo early and frequently. Give them phototherapy. Do exchange transfusions. So partial exchange. Pulling out so many cc's of the patient's blood, replacing it with saline. And when I'm doing a full exchange transfusion, I am taking away so many cc's of the patient's blood, and I'm putting donor blood back into the patient, the same amount of cc's. So I am diluting out that bilirubin in the skin, in the body. I shouldn't have to go completely into education and support, but remember, these kids, if they're under phototherapy, they need to be under that light as much as possible. So only out from under the lights during breastfeeding. If a kiddo's crying, does not mean I need to pull them out. from the lights and they need to be breastfed. They shouldn't need to be breastfed that often. Different ways to calm that child so they can be under the lights as possible. If I'm going to be under phototherapy lights, what do I need to protect? The groin and the eyes, right? Making sure I'm flipping the child so as much of the skin is being protected. The feeding of the frequent fluids. We don't want them to be dehydrated. Okay, so blood incompatibilities. What's going on? Maternal antibodies respond to antigens from that fetal blood crossing the placenta. So this results in fetal anemia, jaundice, and increased bilirubin level. This is due to Rh incompatibility or ABO incompatibility. Rh incompatibility is when the mom is Rh negative and the dad is Rh positive. The baby is either negative or positive. It's going to be worse if that baby is positive because the mom's antibodies are going to fight against that baby. We are going to give that mom the RhoGAM shot. Okay. If that baby is negative, we have no problems. If that baby is positive, the mother forms antibodies against the fetal blood cells. Okay, those antibodies are going to be in her circulation. She's going to end up having more pregnancies possibly. Then we're going to have lysis of red blood cells. The fetal erythrocytes become destroyed by those maternal Rh positive antibodies. And that's going to cause the bilirubin level to increase. The fetus compensates by making large numbers of the immature erythrocytes to replace those hemolyzed ones. And we're going to have erythroblatosis fetalis. It could kill the babies, especially the ones after this first one. Okay, how do we treat this child? Transfusions every 2 weeks, possibly. Intrauterine and then extern once that baby's born, we may need to. We do Coombs tests at the first prenatal visit and again at 28 weeks. This determines the presence of those maternal antibodies and if the mother has been sensitized. Okay. At birth, the infant's cord blood is sent to the lab to determine the type and the Rh factor. Coombs test determines if the maternal antibodies are present in fetal blood. Like I said earlier, we need to feed that child early and regularly to stimulate stooling and peeing, and that'll help excrete the bilirubin. Okay, the RhoGAM shot is going to help sensitize that mother from that antigens being produced. ABO incompatibilities. This is more common than Rh incompatibilities, but there's less problems. Okay, we're just going to watch and treat that hyperbilirubinemia. It rarely causes anemia. We're going to have a positive Coombs test. These kids may need exchange transfusions. They may just need more phototherapy, but it is not as deadly. Okay, and that is that for this lecture. Thank you.